This is the Blood Bank Guy Essentials Podcast, episode 041. Hi, everyone. Welcome to today's edition of the Blood Bank Guy Essentials Podcast. I am Joe Chaffin, your host. I'm so glad that you're here with me today. I want to let you know right up front, this is not a continuing education episode. You can check bbguy.org and transfusionnews.com to find episodes that end with the letters CE, so you can get free continuing education credit. The CE episodes are provided by Transfusion News with generous sponsorship from Biorad, who have no editorial input. And that free continuing education, if you haven't already heard, applies to both physicians and laboratorians. So please check that out. Now, for today's topic, when I look back, I see actually that in the first 40 episodes of this podcast, I can't believe we're on episode 41, there's only been one where I was really talking about blood donors, which honestly is a little bit weird because I'm a blood center chief medical officer, but okay. Blood donors are really completely astonishing people. They're amazing people, and they do so much good for so little return. And I love interacting with them. Learners, though, need to be aware that we ask donors questions for a reason. And I have as my guest today someone who's incredibly qualified to tell you some of those reasons. She's my friend, and she is Dr. Mary Townsend. Mary is a senior medical director for blood systems, and she is just incredibly qualified. As I said, she has been part of the AABB Donor History Task Force since its inception, actually, and she's a former chair of that committee. She's going to tell us all about the development and use of the AABB Donor History Questionnaire, affectionately called the DHQ, or sometimes they add a U for uniform, UDHQ. The history is incredibly fascinating, and she really is going to share with us some great nuggets for those of you who might face blood donor questions on standard exams. But even if you're not getting ready for an exam, I think you'll find this really, really interesting to figure out why we ask, what the science is behind it, and how all this fits together. So I can't wait for you to hear it. Here is my interview on blood donor questions with Dr. Mary Townsend. Hey, Mary, welcome to the Blood Bank Guy Essentials Podcast.
Good morning.
It's so great to have you. You and I go back a little ways, and we should just full disclosure tell everyone that we're friends and we have a tendency to get silly. We should just cover that right up front, don't you think?
Well, I think disclosure is best.
It's true. It is true. You know, Mary, so I've already told everyone a little bit about your incredible qualifications. But one thing I did not say, which I think, again, is important to cover right from the beginning, is, your self-designated moniker as the blood bank goddess. I mean, where did that come from? Come on.
Well, you're the blood bank guy. Actually, this goes back a few years when I was the SMT chair for ABC, and the president at that time was Jean Dariotis, and she called herself the blood bank queen. So I couldn't become the blood bank queen, so I thought the next best thing was to become the blood bank goddess. And over time, people who worked with me and for me would give me signs, goddess signs, mugs, coffee mugs with goddesses on them.
That's awesome.
It's self-fulfilling. What can I say?
I like it. It works. That's either way, whether it's goddess or queen, you guys all outrank me. So I'm totally good with that. So our topic for today is the donor history questionnaire and how it's used, where it comes from. I just kind of want to take us from the beginning because, again, we're talking about a lot of folks that may not completely have a great background in donor qualification stuff. I'll just start with a real simple question, and that's that, there's tons of donor centers all over the United States, and we're going to focus mostly on the United States here for obvious reasons. So does everybody just decide what the heck they want to ask their donors, or is there any structure to it?
Oh, I wish. Actually, in blood banking, we're dictated by AABB standards, by FDA, and FDA and AABB both have a lot to say about donor screening because it's considered by FDA as one of the pillars of safety. So, this interaction between donor screening, AABB, FDA goes way back. And no one is told in the United States exactly what they have to do, but as long as they meet FDA and ABB criteria, they're good to go.
If that's the case, has anyone given any guidance to people on, how to meet those AABB and FDA criteria?
Well, I think the best answer to that is that AABB has published their standards. FDA has put out multiple guidances.
Right.
And if somebody wanted to do this on their own, they just have to pick through all those things and be sure that what they're doing matches those. I mean, obviously, having an approved donor questionnaire makes it very easy. But there's no rule that says you have to use this donor questionnaire. I think the bulk of donor screening is done with it because of the convenience of it. All the work was done for you.
Well, so let's talk about that work. How did that? So you're talking about a quote unquote standard donor history questionnaire. It's gone by several different names over its lifespan. I think it was used
some
to be
printable, some not.
That's well said. That's certainly true. But how did we get to the point where we are now? And we're going to spend a lot of time today talking about version 2.0 of the AABB donor history questionnaire. So how did we get there? What's the history behind that?
Oh, man. Well, let's start. Let's just give a 2 or 1 minute background about how all this started. I mean, if you really want to go back to the beginning, you go back to the Spanish Civil War. This is like,
oh, wow.
Yeah, this is like 3/4 of a century ago. And this was shortly after blood transfusion had started. And there was a physician, Federico Duran Jorda, in Barcelona, and he started testing donors for syphilis. And then there was a Canadian surgeon, Norman Bethune, in Madrid, who started asking donors to swear on their honor that they had not been previously infected with syphilis. That's how donor screening started. And then, after that, the AABB donor record card came about in 1953, asking about 21 diseases and conditions. Obviously, things changed big times in the 1980s with HIV. I mean, that's really where it became very serious, what and how we were asking things. That's when FDA really got involved. Obviously, questions were added to the questionnaire sporadically over the decades, but in the mid-1980s through the 1990s and 2000, questions got added on all the time. I mean, just routinely. And, what was initially a short questionnaire became really big and bulky. I think eventually it had 75 questions about 75 health, travel, medication, and infectious disease items.
Brutal.
Mm-hmm.
It is.
Yeah.
It's a marathon to even answer the questionnaire.
It is. It was, and it still is. But to an extent. What we wanted to do was make it easier and better.
And that brings us to the creation of the Donor History Task Force. Was that created in response to all the crazy number of questions that were on there, and as a way to try and streamline it, or what was the driving force for the Donor History Task Force creation, Mary?
I think it's what you said. I mean, it was very long, very complex. When you looked at the questions, there were compound questions, multi-item questions. Mm-hmm. And right before 2000, AABB sent out a survey to blood banks asking about the donor questionnaire. And you ask, you're going to hear back, and you're going to hear the good, the bad, and the ugly. And they heard back about all the issues that people were having with the questionnaire. A lot of the problems were with medications and travel. Nothing's changed. There were just a lot of problems with the questionnaire in terms of using it and donor understanding of it. And so because of that, actually in 2000, it was the FDA who came to AABB and asked them, could you put together a task force and look at the questionnaire and improve it? So that was the start.
Okay. Is it my understanding that you've been part of that task force from the very beginning, Mary?
I have, and I still am. I think I'm one of two people who started and are still on the task force.
Yes, and I know at one point you were actually the chair of that committee, right?
I was the second chair. Yeah.
Well, so I guess I'm interested in having you take us through a little bit of the process of how you guys took this massive beast of a set of questions and tried to pare it down. In particular, I guess, I know there have been several iterations since then. And as I said before, we're on version 2.0 right now. But when you guys were trying to figure out how do we pare this down? How do we ask what matters, avoid asking what doesn't matter, and present it in a way that's going to be useful to the donors? How do you even start with climbing that mountain?
Well, I think you hit on it. The number one question that we asked ourselves at the start was, what is our goal? What is it we're really looking at? What's important? What's not important? So we really took all the questions and went by them one by one. We looked at, why are we asking this question? Is there anything that AABB has to say about it? Is there anything that FDA has to say about it? Is there anything we know about why this question is being asked? And sadly, most of the questions on the donor questionnaire were really based on, not on data, but on opinion, tradition, conventional wisdom. And so we were trying to take this apart, look at what's really necessary, what do we have to put on there because of regulations, what's really indicated, and then once you look at what is this item that we're interested in, what's the best way to get the information? And in fact, we decided in some cases the best way to get the information wasn't to ask a question. We had many questions on the donor questionnaire that ask about HIV risk factors. And we decided that the best thing to do was take those things off of the questionnaire and put them in really good donor information material. So our focus then was to look at the donor information material that we give out, look at the questionnaire. Obviously, one of the big issues we had was with medications. And so we took a completely different approach with medications. We used to ask every single medication was a question.
Ugh.
Every time you added a new medication, you had to add a new question to the questionnaire. And back in those days, they were paper questionnaires. And sometimes they were multi-forms where you fill it out and you have, how are those multi-forms work? And so to print those and reprint those multi-forms was really onerous and really expensive. So if you added 2 questions in 1 year and you had to reprint all your donor questionnaires, it was really... So we took all the medications off of the medication deferral list except for aspirin and antibiotics. And we put them on a separate list. So what we were trying to do was, what's the target question? What's the best way to get the information? And in doing that, we used what we called cognitive psychology. We actually have cognitive psychologists working with us on the questionnaire. We had survey specialists working with us. All the questionnaires that have been put together, there was no rhyme or reason. They just made up a question and put it on there. And it didn't matter if it was a good question or a bad question. And so now we're starting to look at the science of surveys, the science of asking questions and getting information. So things like attention, memory, higher thinking skills, these were considered in putting the new questionnaire together.
I don't think many people appreciate the science that's behind what you guys have done with this. It's not just randomly throwing things into categories, but you've actually structured this in a way intentionally to try and move people through questions in a way that's going to allow them to process it better. Is that a reasonable way to summarize it?
Exactly. And some of the things were not that difficult. I mean, it doesn't take a brain surgeon to figure out that a question like, this is one of the questions we used to ask. In the last 6 months, have you had a tattoo, ear piercing, skin piercing, acupuncture, electrolysis, injury from a needle, or come in contact with someone else's blood? That was the question.
Well, that seems simple enough to me. Come on.
That seems simple enough. Which question am I supposed to answer? Right. And it was like, people can't answer compound questions like that. It's bad enough even if it just has 2 things on there. And so what we did was we broke up the compound multi-item questions and made them single questions. And that helps focus. I mean, you're focusing on one behavior and not multiple behaviors. We tried to cut out a lot of the medical terminology that donors didn't recognize. I think one of the biggest things we did was we put a stop to time travel. And by time travel, in the original questionnaires, people were asked, have you had a shot in the last 12 months? Have you ever done IV drugs? In the last 2 weeks, have you had aspirin? I mean, people were doing mental time travel. What did I do 2 weeks ago? What did I do a month ago? So what we did was we formatted the questionnaire to go backward in time. So we start the questionnaire with today. How are you feeling today? Then we go back 48 hours. Have you taken aspirin? Then we go back 6 weeks. Have you been pregnant? We go back 8 weeks. Have you given blood? We go back 12 months. And we ask a lot of things about what have you done in 12 months. And then we get to the ever questions. So people don't have to do mental time travel. They can go back in a logical sequence and look at these questions and focus on a specific time frame going back. And I think that was a really worthwhile thing to do.
Mm-hmm. Well, so, and I wish that we had the time today to go over each and every one of the things that you guys changed, but I think that gives us a great overall summary, and we're going to hit some of the specific topics in just a second, Mary. But before we get to that, there's a couple things that I want to just hit real fast, and that's, a lot of times when people think about the donor history questionnaire, they think about this, this set of 43 questions that you can find on the AABB website. But it's, you guys intentionally, and you kind of alluded to this earlier, it's not just the questionnaire. There's multiple parts to this whole packet. Can you just kind of summarize what the whole deal is? It's intended not to be used just as okay, here's some questions, but there's supporting materials, right?
Exactly. So we start with donor education materials. Those were developed, again, with assistance of experts. And they're very, we try to make them as brief as we could because we know people come in, they're not going to read pages and pages. What's important? And so we put those things on the donor education materials. Covering things like HIV symptoms, covering things like it's really important that you tell us the truth. Don't get an HIV, don't donate to get an HIV test. Really important big items go on that. Then there's the donor questionnaire, which was developed and then tested, and we can talk a minute about how it is tested if you want.
Sure, yeah, please.
Because it is a validated questionnaire. It's the first time we've had a validated questionnaire. And then we have a user brochure, because you think about, you give somebody a medicine, you give them a package insert. Well, we needed a package insert. And the user brochure describes some of the new concepts, capture questions. So we ask a big capture question like, in the last 3 years, have you been outside the United States or Canada? So that's a big capture question. If someone says no, they're off. If they say yes, then you ask a bunch more questions. So the user brochure basically told people, what have we changed? How do you use this? Basic instructions for use. And then, of course, the medication deferral list, which is near and dear to my heart. Uh-huh. And that's a separate document, and it's maintained separately. So that's really the big pieces.
Got it. Okay, so we have this, and anyone can go to the AABB website and find this, and I'll include a link to it on the show page for this episode, which will be at bbguide.org/041. But so people can take a look at this. People can see, and it's formatted in a particular way. There's the words are obviously all easily seen, etc. So one of the questions that people ask a lot, Mary, and I think it's important for learners to understand this, is so this is something that you guys did a lot of work on. This is something that has, as you said, the questions have been validated. So if you are in a situation where you see this and you go, okay, here's AABB's work. How can I change this? What can I do to make it different? I don't like the way they worded this question. What are the options for individual centers in the United States that are following these, using the DHQ 2.0? What are their options for modifying?
That's a really good question, because a lot of people do want to or need to make modifications. One prime example is if you're collecting plasma for Europe, you have to ask additional questions. You have to ask about colonoscopies and endoscopies and stuff. So yes, you can, if you want to use the UDHQ, Uniform Donor History Questionnaire, as is. You don't have to get any approval from FDA, AABB. You send it in as an annual report. If you want to add questions, you can do that, but you have to add them either at the very beginning or at the very end, because the questionnaire was validated as a whole. So you can't insert questions. Now, if you decide you want to insert a question, you certainly can. But if you do that, it changes the basic questionnaire, and you're going to have to take that through your CSO and get FDA approval.
Mary, just for people that are beginning, help us understand that. CSO for FDA approval. What do those abbreviations mean?
Okay, so the CSO is a consumer safety officer, and it's sort of your liaison between your blood collection facility and FDA. So if you have specific questions that you want to address, you don't just call FDA, you go to your CSO, and they can either answer the question directly or they go into FDA and get the answer and come back to you. So it's really very useful, yeah.
So you were saying that that if they want to make a change, they talk to their CSO, add a question, or fundamentally change the questionnaire. They add a question. Are places doing that, Mary? Is that something that different blood centers in the United States are currently doing?
I think some do, and I think they have to. As I said, if you sell plasma to Europe, to the European Union, you do have to add a few extra questions. And as I said, you can add those questions at the end. If you add them at the end, you actually don't have to get FDA approval. It's only if you insert them into the body of the document.
Yeah, because you guys have done a lot of work on making this beautiful 43 question progression.
Right.
That is, as you said, I keep coming back to this, and I think it's a really important point. It is validated. It is tested to show that it does what you wanted it to.
Right.
Okay, Mary. So we don't have the time to go through each and every change that was made in version 2.0, nor do I think we should, but I think that there are important things that people that are learning about blood banking need to be aware of. And that's not just for people that are studying for exams or preparing for exams, like pathology residents and laboratory students. I think there's a lot of stuff out there that may surprise people that just don't know a whole lot about what we ask donors. So let's start with, if you are willing, the thing that's so near and dear to your heart, and that is the fabulous medication deferral list. I think you set this up wonderfully when you told us, and I remember these days too, when donors would come in and they'd be asked to list out every single medication, and we'd refer to different lists that say this medication's okay, that one's not okay. Oh my goodness, it was painful. It was awful.
Well, and what makes it really fun is that we have generic and we have brand names. So it's like, how many ways can we ask this?
Oh, it's impossible. It was impossible. It really was. And it was one of the things that people really disliked about donating blood. So again, take us through a little bit. Why do we ask donors about the medications that they're on? And B, what are the changes that you guys made to streamline the medication deferral list?
Okay. Well, let's talk about why we even ask about medications. For the most part, we really don't care what medicines people are on. For the most part.
Wait. What?
I mean, think about how many medications are out there, how many hundreds of thousands of medications are out there. And we ask about a very short list. And there's a very specific reason why we ask about every one of these medications. Most of the medications that were added early on to the medication deferral list were teratogens. In other words, if you had a high titer or a high quantity of this medication in your blood, and your blood was given to a pregnant woman, could it cross the placenta and get to the baby and cause birth defects? So that was probably one of the big ones. And so you're looking at things like Accutane, things like that. Then there are medications on there that are specifically designated because they impact the potency of the blood product. So, example, if somebody's taking an antiplatelet medication, Feldene, Plavix, there's several on there. Well, obviously, if they're taking a medication that impacts the platelets, you don't want them to be the sole platelet donor. So you wouldn't want to do apheresis on them. No, certainly they could give whole blood, but we wouldn't want them giving platelets. Same thing for aspirin. That you can give whole blood, but you don't want to give platelets as the sole platelet donor. The other category that's really just like that is anticoagulants or blood thinners. I mean, it's not going to hurt the donor, if they're taking Coumadin or something for their atrial fibrillation. I mean, they're going to have to stay on that the rest of their life, or an equivalent, whatever the drug of the day is, whatever they're advertising on TV.
Sure.
Eliquis, yes.
Right, exactly.
But obviously, if you collected a plasma for FFP for transfusion from a donor like that, it would not be potent. It wouldn't confer the potency that you're using that product for. So we use those. Really, an obvious one is hepatitis B immune globulin. The only reason you give HBIG or hepatitis B immune globulin is if somebody had an exposure to hepatitis. It's really not the drug we care about. It's the fact that they had an exposure to hepatitis. A biggie on there are the medications that are targeted to a risk for VCJD or CJD. So growth hormone from human pituitary glands, that's a permanent deferral because of the CJD risk. Insulin from cows manufactured in the UK, that's a VCJD risk. So that's really, if you look at it, that's only about 4 different indications for putting a medication on this list.
So tell us, Mary, how does a medication actually get on this list? Do you guys just wake up one day and say, I want to make life harder for donor centers, and I'm being facetious, and add another medication? There just this month, we're recording this in November 2017. There was a revision, an addition to the list, which I think is a basal cell.
Adomza, yeah.
Adomza, yes. So why don't you take us? How did that medication come across the task force's radar, and you guys decided to put that on?
Well, that's pretty funny because actually, your initial observation is probably pretty close. Sometimes, actually, it's really funny. Maybe funny, not whatever you want to say. One day I was watching an ad on TV for a medication, and I can't remember which one it was. It was one of the prostate or or hair remedy. And they actually said on the advertisement on TV, while you're using this medication, you shouldn't donate blood. Well, God, that got my attention.
Oh, my goodness.
And it was like, wait a minute, is this on the list? And it wasn't. So there are lots and lots of medications that come onto the market every year. And so when these come to our attention, and somebody usually has to bring it to our attention, we actually now have a process. It's really, really nice. We have a group of people who looks at each medication that comes to our attention. And we have a PharmD who is really excellent with working with us. And what she does is she looks at each medication. We say, what do you think about this medication? And she evaluates it. And she looks at, okay, how is the drug metabolized? Is it metabolized through the liver, et cetera? What's the half-life? I mean, if a drug, like a new medication came to our attention this year, and I can't remember what it was, well, the half-life was 2 hours. You know, by the time a donor takes a drug and gets to the donor center, the drug is completely metabolized. So you look at the half-life, you look at all the pharmacokinetics that you consider when you have a drug, and you think about how much of this drug is going to be left in the plasma that's on a unit of whole blood. And you think about, we spin these down, there's very little plasma left. And if you think about the plasma levels of these drugs, by the time you get a few cc's of plasma and you have very low plasma levels, the recipient's getting very, very low levels of drugs. Now, that's not necessarily the case for something like platelets or plasma, which has a higher volume. But if you have it, you know, just really, really low levels of any drug in your bloodstream, it has much less effect. And so we're not going to be as concerned. So, yeah, we really do have a scientific way to evaluate each of these drugs that comes on to our attention. And I might mention to our listeners, if they hear of a drug, there is a way. You go onto the AABB website, and I can get you that link. It's, I think, the regulatory, and you just send them an email and say, oh, I just heard about this new medication. Should it be considered for the medication deferral list? And it comes to our group, and we evaluate it, and we make a decision.
I will get that link from you, Mary, and everyone. That will be on the show page again at bbguide.org/041. All right, cool. So we need to move on a little bit, Mary. I know that's your baby. So are you okay if we move on?
We're good.
All right, fair enough. Let's talk a little bit about vaccinations. Okay, so we ask people in question 8, I believe, of the version 2.0 of the DHQ in the past 8 weeks. Have you had any vaccinations or other shots? Why do we care about whether people have had vaccinations?
Okay, well, we care about vaccinations mostly because some vaccinations can carry a residual risk for infection. So we're mostly talking about not if a vaccination is taken from an inactivated virus or bacteria, obviously it's not going to cause an infection.
Sure.
Today we have so many vaccinations that are recombinant. Obviously, there would be no deferral for those. The ones that we're most concerned about are the attenuated vaccines, because these vaccines are really they're living organisms. They have not been killed. They've just been taken through the laboratory. They've passed through the Petri dishes so many times that they've lost their potency. They really just completely have no potency. The value of an attenuated vaccination is that it's much more immunogenic because it is an actual pathogen. It's a microbe. And so you really get great response to that. You have great immunogenicity. And so especially for viruses, that's a really good way to get a potent vaccine. But most new vaccines coming out are really either killed or recombinant.
Okay, so so we should cover just a couple of the really common ones that people get, just so because people ask questions about this, and people might get asked questions about this on exam. So the influenza vaccine, Mary, what about that one?
It's okay. Influenza is good.
All good. All right, pneumococcus.
Pneumococcus is good.
Pneumococcus. What if somebody's going to travel and they get a hepatitis A vaccination?
They're good.
They're good. Hepatitis B vaccination.
Hepatitis B is a little bit different. Technically, you're good. Technically, you could get hepatitis B vaccination, come in today and donate, but there's a risk. Because of the hepatitis B vaccine can cause a false positive hepatitis B surface antigen false positivity.
Yes.
And so because of that, and then you lose your donor. I mean, the donor's deferred. So what a lot of blood centers do is they recommend a deferral period. 2 to 3 weeks is generally, 3 weeks is more than enough, 2 weeks is probably enough. And so they pick a number out of the air, 2 weeks, 3 weeks. And after that time, then that false positivity shouldn't occur.
Okay, got it. That's that one. That one is one that the answer on an exam would be no deferral, but in real life, yeah, you'd want him to wait. Okay, what about MMR, measles, mumps, rubella vaccine?
That would be a 4-week deferral. That's a live attenuated vaccine, and so it includes German measles, rubella, chickenpox, and those are the 2 big ones for the 4-week vaccine.
Got it. Yeah. So chickenpox is also a 4-week deferral. People get varicella vaccines often nowadays, I guess.
Both for chickenpox and for shingles.
For shingles, yeah, you bet. That's see commercials about that as well.
Oh yeah.
All right, so we need to move on again. Let us talk about travel deferrals. And I know they're fun, right? I want to start just in general. Again, why do we ask people about travel? I get that question a lot from donors. Why do you care where I traveled? Geez, what's your problem? So what do you tell a donor that says that?
Well, we tell a donor who travels that we're interested in preventing an infection of an infectious disease to the recipient. The ones that we're really concerned about are the ones that you get when you travel. So the biggie, by far, the biggest one is malaria.
Yeah.
And we know malaria. There's no malaria here, but if you go to Africa, you go to parts of China, there's malaria is in all kinds of parts of the world. And that in theory, if you go someplace where there is malaria and you're unprotected, then you have to be deferred for 12 months. The theory being, if you come back and you have no baseline immunity, if you got malaria, you're going to show symptoms. So that's the big one. The complicating fact on malaria is people who have actually lived in a malaria area, and that's FDA defines that as you were there 5 years. So if somebody was born in or lived in a malaria area, then there's a chance that they got malaria, and they have what we call partial immunity. And partial immunity, usually from somebody who grew up in a malaria area, and they have immunity, and it keeps them from getting a clinical case of malaria, but they could still have malaria that is not clinically being expressed. So they could come in and you can ask them, have you had malaria? Well, no. But in truth, they have had malaria. They're just not clinically expressing it. So that's a special case.
So if you don't mind, let's just do a couple of quick examples, because I think it's useful for our listeners to kind of hear how we make these decisions. Let me just give you an example. Okay, let's say that someone decides that they're going to take someone who lives, I don't know, you're in Arizona. Let's say someone who lives in Arizona decides they want to take a vacation in Mexico. And if you go to the CDC map of Mexico, you'll see that some areas show up in bright red as having significant amounts of malaria, and other areas are green, which means no malaria. Let's just imagine that they go to Cancun, which is an area which is green, and a lot of people visit Cancun. So they go there, they stay a week in Cancun, they come back home. All they did was stay there in Cancun, but there's malaria in Mexico. Are they deferred?
They are not deferred because they did not go to a malarial area.
Okay. Well, what if, let's take that same person who traveled to Mexico, and let's just say that they decided to take a day trip over to Mazatlan, which is on the other side and is in bright red. So they go to Mazatlan, but they're there for 12 hours. They come back to Cancun, and then they go home. Are they going to be deferred?
Nope.
No, why not?
Because, well, we're trying to make it as confusing as possible. Not really, but it is. FDA was actually did us a big favor. They were very specific about what travel in a malarial area is, and it has to be greater than 24 hours. And that's because we had travelers who were caught up. They went to a non-malarial area, they got on a bus, they traveled 8 hours through a malarial area, or maybe got on an airplane, traveled through a malarial area for 8 hours during the daytime, and got to another non-malarial area. Do they have to be deferred just because they traveled from point A to point B? And FDA made the determination, no, travel is really if you're there greater than 24 hours. So that's really nice. It really has made a difference. Yeah.
That does help. So 24, that's the key. Those of you that are getting ready for exams, or even those of you that are just trying to learn about this, 24 hours in that endemic area
magic
is
time.
The magic. Absolutely. Okay, good deal. So let's move on from malaria because it kills me, to be
slays me.
honest. All right. So this is where we move into an area that is it's a little more touchy. It's a little bit there are a lot of emotions involved in this area, but let's approach it as dispassionately as we can, and just talk about the decisions that were made regarding things that are considered high risk, quote unquote, contact. Some of these are non-controversial. Some of these are controversial, quite frankly. So let's just start with some of the simple ones. Things like getting blood from someone else, or getting a tissue or organ transplant from someone else. What kind of decisions have been made about that in terms of risk?
These decisions really came, as I said earlier, from the HIV epidemic. And, at that time, sadly, I think over 1,000 people, and maybe more than that, people got HIV through a blood transfusion. So at that time, it became obvious that you could get, it was obvious even before HIV. They knew that you could get syphilis from a blood transfusion. But at that point, it became obvious that you could get some really devastating diseases from a transfusion. And so, the question became, how long do you defer somebody? And, initially deferrals, you tried to have a reasonable deferral. So, let's talk about, have you come into contact with someone else's blood? If you got a disease from getting a blood transfusion, within 12 months, we know that the window period for HIV, hepatitis B, hepatitis C are well under 12 months. So if you get a transfusion and you come back at 12 months later, you donate blood, and all of your tests are negative, you know that you had the opportunity to catch anything that they would have caught. And so they wouldn't be infectious. So 12 months kind of became this magic period for things like, have you had sex with a prostitute? Different ways that you could be exposed to the biggies, hepatitis B, hepatitis C, HIV. Have you had a tattoo? Have you had ear or body piercing? Have you been in jail for 72 consecutive hours? Have you had sexual contact with, say, somebody who had hepatitis? So all of those risk deferrals took on, a specific time period. The obvious one that we're going to talk about, obviously, is MSM. And that was considered a permanent deferral. The other permanent deferral, the other two big permanent deferrals are if you ever traded sex for drugs or money, prostitute, and if you ever used IV drugs. I mean, those were the big three.
And Mary, just for clarification, to make sure everyone understands what we're saying, MSM, help me with that abbreviation.
Males who have sex with other males.
Okay. So that's where we move into territory that, as I said, there's been a lot of discussion, a lot of emotion involved in this. So, I know you and I share this. We are very, very sensitive to those, to the difficulty of those discussions for people on all sides of this issue. But let's just talk about what was changed by the FDA, which led to you guys changing version 2.0.
Yes. The FDA made a major change in the HIV deferral, and they changed it from a permanent deferral to a 12-month deferral. And this was based on scientific evidence. They had data showing that, our sensitivity of testing is really, really extraordinarily sensitive. The window period is very short. So they landed on 12 months. And so we made the change to, in the last 12 months, are you a man who has had sex with another male? That may change in the future. There's obviously a lot of pressure. We want to get away from labels. Actually, it was really very interesting. When we were developing the donor history questionnaire, we were very sensitive about labels. Even when it came to something like a prostitute, we didn't want to use the word prostitute, although it was really hard to get away from that because so many people understand what that means. But we tried to describe not a name, but a behavior. And so that's why, we're trying to get into behaviors. Well, there may be an even better way to get at these risks, and that is to look at individual behaviors. And some of the other countries have started to screen donors based on specific behaviors. So, for example, I'm not saying this is where we're going, but this is just an example. Instead of asking you're a male who's had sex with another male in the last 12 months, you ask any donor, whether male or female, have you had a new sexual partner in the last 3 months? Again, 3 months because it's outside the window period for HIV, hepatitis B, hepatitis C. So you ask a much more direct question. Have you had a new sexual partner? Have you had more than one sexual partner? I mean, these are just examples of questions that have been used and are being explored in other parts of the world to try to get at these risks and get outside of the sensitive issues of lifestyle. We're trying to get beyond lifestyle. Yeah.
Yeah, I totally understand. I think that's very, very well put, Mary. Thank you for going there with me. That's obviously an important topic that's had a lot of discussion. So let's leave it there. And there's a couple more things I want to cover with you before we finish. Let us do a couple of things that I think people will find a little bit surprising, in that there's not a lot of very specific guidance in the materials that you guys put together. And I hope you can help us understand why. And the first of those is question 41 that asks about, have you ever had any problems with your heart or lungs? And when you look at the flowcharts, when you look at the materials, there's not a lot of specific information. Mary, why didn't you guys give us specific guidelines?
Because there is no right or wrong answer on some of these things. I mean, obviously, we're doing two things with the donor questionnaire. We want to protect the recipient from an infectious disease. But we want to protect the donor too. I mean, why do we ask women if they've had a pregnancy? I mean, pregnancy has really never been widely known as a transfusion-transmitted disease. I mean, not that I know of. Thank goodness. So, I mean, obviously a heart attack is not a transfusion-transmitted disease, but we're concerned about if we take a unit of blood or a double red cell or an apheresis product from a donor who has underlying heart or lung conditions, could we put them at risk for having a heart attack? Obviously, if you have pulmonary disease, the way you oxygenate is circulating blood through your lungs, and you oxygenate. You take away the blood, it's harder to circulate oxygen. So somebody with COPD, do we really want to take away, if somebody has a really bad COPD or really bad emphysema, they're struggling to get oxygen. Do we want to take away their oxygen carrying capacity by taking a unit of whole blood from them?
Doesn't make a lot of sense.
It doesn't make a lot of sense. So when it comes to heart-lung questions, we're really wanting to protect the donor. And there's no right or wrong answer. I mean, we know that autologous donors with heart disease have been donating for decades safely. Somebody had a heart attack last month. They come in, they give an autologous unit, they do fine. So we've learned a lot over time about what is and isn't safe. So honestly, most of these are really theoretical. Some of these are practice of medicine. Some of these are conventional wisdom. And that's why we have doctors at blood centers, because these are medical issues. They're medical decisions. And it depends on where your comfort level is, you know. If somebody comes out of a residency and they're a little bit nervous, and they may give you they say, oh, we got to have a long deferral for somebody who had a heart disease. You've been in the business as long as you and I have. It's like, oh, they do fine, let them come in.
So you're saying that it's up to the individual facility medical director to set up those criteria?
Precisely.
Okay, well, the next thing I know, you're going to tell me something completely nuts, like there's no specific deferral for cancer. I guess I should ask you the question. Is there a specific deferral for cancer?
No specific.
What?
Nothing specific by AABB, FDA, nothing at all. It's based purely medical judgment. And it's interesting because when you look at cancer, they actually, many, many years ago, they did some experiments which wouldn't pass IRB approval at this point, but they actually they drew blood from people who had leukemia because they had white cells, and what they wanted to do is give the white cells to recipients who needed white cells, and they ended up giving them leukemic cells, and guess what? No one got leukemia, and that's a blood cancer. Well, if you can give transfuse a blood cancer to somebody and they don't get it, I mean, that tells you pretty much, if somebody has breast cancer and you give their blood to somebody, they're not going to get breast cancer. So it really becomes more of a donor safety issue. And so, it depends on the medical director's comfort level. Obviously, some cancers are bigger than others. Blood cancers, leukemia, lymphoma, generally people are not comfortable and they give them a permanent deferral. But honestly, kids who have acute leukemia as children, they're cured, they're 40 years old. Mm-hmm. I mean, they're not going to have a recurrence of their childhood leukemia. Mm-hmm. There's no reason they can't donate. So I think you can have flexibility even in the blood cancers. For solid tumors, melanoma, people, it used to be permanent, and then all of a sudden everybody was doing 5 years, and then all of a sudden people were doing 2 years, and now people are doing 1 year, 6 months. I mean, it's really a medical call.
Yep. Okay. Well,
no right or wrong.
No, I gotcha. I think your message that cancer is just not transmitted that way is the thing that learners really need to understand. It just doesn't happen that way. So that's good news for all of us. Okay, Mary. So we've covered a lot, and there's obviously still a whole bunch of other stuff we could do. But if you don't mind, let's just do a couple of really quick hitters if we can.
Right.
And in particular, there's a couple of things that were taken off of the DHQ that I just want to get your really quick thumbnail thoughts on why. And the first one is we used to ask a question. if the donor has ever been diagnosed with hepatitis, and we got into weird 11 after the 11th birthday, all that kind of stuff. Well, what was the rationale for taking that off of the DHQ?
Okay, the rationale by FDA, and I think it showed a great deal of wisdom, was that the hepatitises that we're really worried about are hepatitis B and hepatitis C. We already ask a large number of questions that elicit risk for hepatitis B and hepatitis C, as well as HIV. IV drug use, we've talked about some of these, living with a person who has hepatitis. So we're eliciting questions to find these people, and we're testing them with uber sensitive tests. So FDA felt that asking them if they had hepatitis was really getting us nothing. And the big thing was we were losing donors who really were quite safe. People who had hepatitis A when they were 15 or hepatitis A when they were in the Army, who had jaundice for some other unknown reason. So that was taken off for a very good reason.
Okay. So my last question for you is this, and you may or may not have a whole lot to say about this, Mary. Totally up to you. But
you know me, I always have something to say.
That's a valid point. So you obviously have been enormously involved in the development of our criteria and questionnaire here in the United States. About a third of the people that listen to this podcast are actually international, people from Canada and the UK especially, but other countries all around the world. Is there the equivalent of you guys on the task force in different countries? Do they have standard questionnaires?
Definitely. Canada, in fact, the chair of the task force right now is from Canada.
Oh, okay.
Yeah. So we've had people from Canada on the task force since its inception. Obviously, they don't report to FDA. They have their own regulatory body that they answer to, and anytime they take a change, they take it to their own regulatory body. And in Europe, every different European country, if not even European regions within countries, have their own criteria, and they have their own questionnaires and very similar process within those countries. Same thing, Australia. I mean, you look around the world, and different countries have their own regulatory bodies which look at this. They talk. I'm sure that, for example, when we looked at the 12-month MSM change, they used evidence from the UK, which made this change a long time ago. So we actually benefit from some of these differences in other countries because they've relaxed their criteria, and the HIV and hepatitis rates haven't skyrocketed, and so we're able to use that data convincingly here.
Well, Mary, this has been so great, so much information, and I think it's going to be really, really useful for the listeners. So thank you so much for taking the time to hang out with me for a while.
Well, it's been fun. It's always fun to hang out with you.
Thank you, Mary. We'll talk to you soon.
Thank you.
Hey, everyone, it's Joe, back with just a couple of quick closing thoughts. Wow. I am so jazzed that you got to hear all that, because there was so much information there. And yes, there is so much more that could be discussed and could be talked about. The donor history questionnaire has gone through a lot of changes over the years. I've seen a lot in my career. Mary and I alluded to some of that. I think it's really fascinating what gets asked, and nowadays what doesn't necessarily get asked. Anyway, just a reminder, you can go to bbguy.org/041. You can find a transcript of this episode, and I'm developing a little quiz to remind you some of the important stuff. And importantly, if you've never seen it before, you'll find the link to the actual AABB donor history questionnaire there. I read every comment, so I encourage you to go there, check it out. please comment on what you heard today, and I'd be happy to interact with you. My thanks to Dr. Mary Townsend for appearing on the podcast with me today. Thanks to each and every one of you for listening and for your feedback, which I do see. Thank you so much for all the great comments on iTunes. So that is all for today, everyone. Thank you again. And as we close, I hope that as you go through your day, that you'll smile and have fun. And above all, never, ever stop learning. Thank you so much. We'll catch you next time on the podcast.